Well, there's been a radical change in life expectancy. I mean, back in 1900, life expectancy was about 50 in most developed countries. Today, it's up close to 80, a little bit higher for women, 82, 83, depending on where you are in the world. And so, a 30 to 33-year increase in life expectancy at birth in a single century, we've never witnessed anything like that before. The vast majority of that was a result of reductions in early age mortality, saving children from dying from infectious diseases. Latter part of the 20th century, reductions in death rates at middle and older ages. And so going forward, since we've already achieved the gains that can be achieved by reducing early age mortality, all future gains in life expectancy are going to have to result from reductions in death rates at middle and older ages. So the game that we're playing today in terms of longevity is a totally different game than the one that we played a century ago. And now aging gets in the way. So if we don't find a way to somehow influence the underlying biological process of aging, the gains in life expectancy must slow down. And in fact, they have in recent decades. So, the question is, how much further can we push out the envelope of human survival? It depends on what time frame you're talking about and whether or not medical technology and aging science comes on line to influence this process. I've always considered that there was a glass ceiling to life expectancy of about 85, about 88 for women and about 82 for men. We could break through that glass ceiling with interventions in aging biology, and the science is progressing very rapidly. But trying to make us live longer, I would argue, is not the goal, should not be the goal. It should be trying to make us live healthier longer. Improvements in health span should be what we're trying to do. Back in 2000, there was a story that appeared in Scientific American where a colleague of mine was claiming that the first 150-year-old person might actually already be born. They're very young now, and they may make it to 150. And I called him up. He's a friend of mine, Steve Ostad, and I said, Steve, you don't really believe that somebody's going to make it to 150. And actually, I think part of the story implied that the life expectancy for a population was going to get up to 150. There's a huge difference between one person living to 150 and the life expectancy at birth of a population making it to 150. And I said, you're not talking about life expectancy, you're talking about one person, right? And he goes, yeah. And I said, you really think somebody can break Jean Calment's record of 122 and a half? That's the longest that anyone has ever lived. By 27 and a half years. And he said, yeah, I actually think it's possible. So I said, yeah, would you be willing to put some money down on that as a bet? And of course, the obvious thing was we each put down $150 to represent the number of years that someone would have to live. The bet was, would anyone alive in the year 2000 be alive in the year 2150? And if someone is alive in 2150 that was alive in 2000, then all of that money is going to go to his ancestors. And if no one is alive,
his descendants,
then my ancestors will get it. And we actually doubled the bet a couple of years ago, and I invested it really wisely, I will tell you. I invested it in gold to begin with, and then I invested it in Tesla. And so it will be more than $1 billion in the year 2150. And I'm pleased to say that Steve is going to be contributing to the future of my family with this bet, because he's got no chance of winning it. Now, he'll tell you the exact opposite, of course, but neither of us are going to be around to know what actually happens. Yeah, so there's some real exciting developments going on in the field of aging today that's focusing in on trying to slow the underlying biological process. You have to realize that modern medicine today is really zeroed in on treating one disease at a time. It's the old infectious disease model from 100 years ago applied to chronic diseases at later ages, right? A physician will see their patient, the patient will have a particular disease, they come in, the doctor fixes them, pushes them back out the door until they come back again. And when this was done 100 years ago, they were pushing children out the door, right? They're helping them survive infectious diseases. Well, the price we had to pay for those additional 30 years of life that we got in the last 100 years was the rise of heart disease, cancer, stroke, Alzheimer's, the things that go wrong with aging bodies. So modern medicine is currently focused on treating one disease at a time, and many of us in the world of aging and aging science are suggesting that's going to run out of steam. In fact, not only is it going to run out of steam, there's a potential for increases in frailty and disability among the survivors in the future as a result of the medical model just reducing one disease at a time. Remember, you reduce the risk of heart disease or cancer or stroke, you expose the saved population to an elevated risk of whatever's left, of which there is a lot. So science has really zeroed in on trying to go after the underlying risk factor for most of the things that go wrong with us as we grow older, and that's the underlying process of aging. It's not hypothetical. People used to think that this was theoretical or hypothetical, but the fact is that there are people already with us today, already around us, that are already aging at a slower rate, just due to basic genetics. They're genetically different than the rest of us. They appear to be aging or senescing at a slower rate. Scientists are trying to figure out what it is about them that it leads to a slowdown in the rate of their biological aging. What that means, by the way, is 1 year of clock time is matched by less than 1 year of biological time. So a year from now, while they're chronologically a year older, biologically they're not. They may be a half a year older than they are today. So researchers are trying to zero in on some various factors that might be able to influence this underlying biological process of aging so that we could slow it down and retain our youthful vigor for a longer time period. The goal is not to make us live longer. The goal is not life extension. The goal is health extension. It's trying to compress the period of frailty and disability into a shorter time period to allow us to retain our youthful vigor for a longer time period, as we think that should be the primary goal. So it's an interesting question that you're asking, because the healthier, longer lives are not going to come about necessarily by altering our lifestyles today. Now, truth be told, there's plenty of low-hanging fruit, right? We could all stand to lose some weight and exercise some more, and avoid the things that shorten life, like smoking cigarettes or eating too much or excessive exposure to sun. And that, of course, there's nothing there has changed at all. Your grandmother probably had that advice for you long ago of things to do and not to do, and they were probably right back then. So public health has a role to play in utilizing the resources that we have available to help us live as long as possible in these bodies the way they are today. But aging science is fundamentally different. Aging science is not standard public health as we know it today. Aging science is really trying to figure out why it is that some individuals, some subgroups of the population age or senesce at a slower rate. And this isn't behavioral, it's biological. And so we're trying to figure out what the biological forces are that enable these people to senesce at a slower rate so that we can confer that advantage to the rest of us. So it may be some particular type of therapeutic intervention. It may be a pill of some kind. Researchers have been studying caloric restriction, reduction in caloric intake for quite some time, recognizing that restricting access to calories may have some beneficial effect, but there's lots of other potential therapeutic interventions that have the ability to do the same thing, but it's not standard public health. It's new public health. It's sort of the new wave of a way of thinking about public health in the future. I've called it primary prevention with a capital P. Typical prevention is, don't eat too much and make sure you exercise and control your weight. That's standard primary prevention, clean water, refrigeration. This has all been with us for more than a century. That's not the way this is going to happen. Aging science is going to come about through basic science to discover what the genes are that these individuals possess that enable them to senesce or age more slowly, and to develop therapeutic interventions that will be brought to the public, designed specifically for the purpose of reducing a broad range of diseases simultaneously. So it's a totally different game that we're playing. It's not traditional public health. It's happening at breakneck speed. I mean, it is wonderful to see the investment in research in geroscience, or the Longevity Dividend Initiative. That's the term that I used for it, but geroscience actually says it much easier. Yeah, there's been an enormous investment in this for a couple of reasons, by the way. One of which is you've got some individuals that are investing in geroscience because they realize that they want their name down in history as one of the contributors to this new, foundational change in our concepts of public health, but others want to profit from it. I mean, look, think about it for a second. If we do in fact come up with a therapeutic intervention that slows aging even by a little bit, it'll be worth its weight in gold to whomever develops this. And so you have all of these entrepreneurs lining up, trying to invest in, whatever they think is the most likely intervention that's going to work. And it's good in a way because it accelerates the research, which I think is important, to accelerate the work on aging science. It's dangerous in a way because anytime you have money coming in from the outside, you have investors wanting to see results, and then you have scientists wanting to exaggerate or embellish what they've accomplished or what's already been done, and we've seen some of that already, but it doesn't dampen the excitement. And again, critically important, this is not hypothetical anymore. Research studies have already been done demonstrating that aging can be modified in other species, including mammals, and we're just another mammal, and there's a reason to believe that these will work in us. Well, yeah, two different issues. So regulating it, boy, that's a difficult one, and I'm really up for free enterprise. I like the idea of testing all of these ideas. There's lots of ideas. Some are a bit more far-fetched than others, but you never know which one is going to pan out. So personally, I'm a big fan of pursuing them all as long as public health is protected. As long as we're not conducting experiments on people, or people are not conducting experiments on themselves, which is happening, by the way. But we have to be very clear that we need to do good science in evaluating these potential therapeutic interventions. You do not introduce a therapeutic intervention to modulate aging to the general public without it being tested for safety and efficacy first. And this is absolutely critical in public health. And unfortunately, in the world of aging and aging science, as soon as good science is done and somebody discovers a potential therapeutic intervention, there's somebody over in the other side of the world saying, all right, let's manufacture this and start selling it before the science is indicating that it's safe and efficacious. And that's been called the anti-aging industry, which I refer to as the second oldest profession. People have been doing that for thousands of years, trying to sell some therapy that is going to, reverse aging or make somebody immortal. And, virtually all the folks that have been selling that kind of stuff, they're all dead. And they all died from the same causes at about the same ages as everyone else. So the concept of anti-aging medicine's been around for a long time. So when you mention regulation, that's what I think of is make sure we do good science, we do it right. While I like the idea of accelerating the research as best as we can, it still has to be done within the confines of good science. And we have to have measurable outcomes. Look, think about it for a second. If somebody comes along with a therapeutic intervention and they say, this is going to make you live to 150 or 200 years, you have to ask, how do you know that? If somebody says you're going to live to 150 and no one's lived past 122, then somebody who's making that claim is making it up out of thin air. It may be based on some percentage improvement in lifespan in another species, but clearly you have to have empirical evidence to document this. And it's one of the biggest problems in the field is these claims of radical life extension associated with any potential therapeutic intervention. It's an untestable hypothesis. You can't make a determination that somebody is going to live to 150 until you wait until somebody takes the intervention and lives to 150. And so it's just not doable. So if you cannot test the hypothesis of radical life extension, we should not be proposing radical life extension. I would actually suggest that the focus should not be on life extension at all. It should be on extending the period of healthy lifespan, and that is something that we can measure and we can observe in a reasonable time frame. If we live longer, that's a bonus. That's great. I hope it happens. But we can't measure it, and if you can't measure it, you can't defend it as an outcome of a scientific approach to modulate aging. So clearly, there's subgroups of the population that live much longer lives, including the royal family comes from a history of exceptionally long-lived individuals. But that may be a demonstration of the life extending benefits of privilege, access to health care, access to good food, the avoidance of poverty, the kinds of things that we know shorten life. If we could, develop similar conditions for the rest of the population, we probably would gain some additional time, some additional life expectancy. With presidents, with U.S. presidents, it's an interesting story. The reason I wrote that paper, ironically enough, was that there was a physician that I saw on TV who was referring to President Obama, who's celebrating his 50th birthday, and the commentary was, oh yeah, we all know that the presidency ages people very rapidly, but the implication is that they live shorter lives. And I'm from Chicago, where Obama comes from, and I'm watching this on TV, and I'm going, yeah, I do work in the field of aging and longevity, and I never heard that before. So since it's a simple testable hypothesis, I just simply went and took a look to see how long presidents lived relative to what would have been predicted for them based on the year in which they came into office. And the evidence clearly demonstrated that the presidents lived much, much longer on average than the population from which they came, including, and this, you see the same thing among British monarchs, that the life expectancy in general tends to be longer. Again, I think it's a sort of a classic example of privilege and the benefits associated with it. And we're not going to get an equitable distribution of finances and healthcare resources, so don't expect everyone to live as long as U.S. presidents or British monarchs, but it does tell you an important story that it is possible under certain conditions to push out the envelope of survival into extreme old age. And the Queen is, 96 now? Or?
A couple of days ago,
yeah, so she's having her birthday here pretty soon, if she hasn't already. And so we've been following that very carefully. And clearly you can't make it out to those ages unless you won the genetic lottery at birth. She won the genetic lottery at birth, no question. And many others have as well. It's roughly about 15% of the population of any birth cohort has the potential to live to 100. Some of my colleagues actually argue that half of the population can live that long, but there's never been any evidence to support that. We've only seen at a maximum about 10 to 15% can make it out to 100. It's really quite simple. The term itself, by the way, comes from the peace dividend. The peace dividend was the Clinton era in the United States when we weren't spending a lot of money on war, and so we were investing that money elsewhere, and it was a wonderful dividend. The concept of a longevity dividend is the benefits that would accrue to individuals and societies if we find a way to extend the period of healthy life and slow the biological process of aging. And the benefits are huge. They're not trivial. I think we've demonstrated, certainly, and some of our colleagues here in the UK have demonstrated quite convincingly, that even just a tiny, modest increase in the health span, a modest improvement or slowdown in the rate of biological aging has a cascading effect on all fatal and disabling diseases simultaneously. So the financial benefits associated with the longevity dividend or geroscience are enormous and worth the investment. And it's one of the reasons why we're at a meeting here today in the UK, in part to address these kinds of issues, and why aging science has accelerated so rapidly. It's because it's such a promising area of research going forward, and I honestly believe that there will be a breakthrough. There will be one or more therapeutic interventions that we will be taking in our lifetime, and we as individuals will benefit, and the society, the country in which we live will benefit from having more healthy older individuals in that society, and that, my friend, is the longevity dividend.